Hello, everyone. Good afternoon from the East Coast. Good morning from the West Coast. Thank you for joining us today. We're going to give a few minutes so that everyone can get logged in here. So today we are going to be talking about optimizing cardiac outcomes in Duchenne and what families need to know. And I wanted to let you know that we will have a Q&A here at the bottom of the screen. You will see the Q&A with a question mark. If you have questions during the webinar, please feel free to enter them into that section. This is being recorded, so it is something that if you would like to go back and watch again or share it, that will be, you will have the ability to do that. We're also hoping to be also live on Facebook. So if you have any questions there as well, we will do our best to get through as many questions as we can. One thing is we won't be really discussing specific patient situations. We will do our best to answer as many questions as we get. We will be focusing solely on current treatments available for the treatment of Duchenne for cardiac patients. And we'll give it a few more minutes so that we get more people in here. But I'm very excited. I personally know Dr. Barth, and I know he's amazing, but you will see at the end of this that you will agree with me wholeheartedly. So, Dr. Barth is the medical director for the Center of Inherited Diseases, as well as the associate professor of clinical and genetic medicine at Johns Hopkins, and that would be in Baltimore, Maryland. So Dr. Barth is going to come on. He's going to go through some slides. We have shared the questions with him that you've asked prior to, and he's going to be going over, like we said, as many as possible. So a few more minutes, and then we'll just get started. So Dr. Barth, if you want to turn your camera on and join us, that would be fabulous. And we thank you so much for spending your time with us and appreciate all of the information that you're going to share with the community. There you are. Thank you
Wonderful.
so much. Thank you so much for being here, Dr. Barth. We really appreciate it. And, for cardiac in Duchenne guys is super important, especially as they get older. And we need, more experts as they get older so that we can continue to care for adults with Duchenne as well. But I'm going to stop talking. I'm going to turn my camera off and I'm going to give it to you.
Thank you so much, Cheryl. I really appreciate your very kind introduction. And I'd like to take a moment to extend my heartfelt thanks to CureDuchenne for inviting me to speak today. I know that this is a very important and inspiring organization who has had a profound impact on the community and really made a pronounced impact on many, many individual families. So thank you again for having me. So today we're going to talk about optimizing cardiac outcomes in Duchenne and what families need to know. And Cheryl shared with me a lot of the questions that were asked by individual families, including why is the heart affected in DMD? When do cardiac symptoms typically appear? We primarily focus on EF, but what else happens to our guys' hearts? What kind of diagnostic testing do we need to know? Are there blood tests like troponins, proBNP, MRI, echo that are important? Then there were many, many questions regarding medications. How do we prevent fibrosis? At what age should we start treatment? There are all these different medications that are available. What are individual differences between beta blockers, ACE inhibitors? What are new and emerging treatments? And then there were some questions about loop recorders, other implantables, about lifestyle considerations, and coordinating care with the neurology and pulmonary teams. Now, this really covers the whole spectrum, and I try to answer as many questions as I can. And whatever I won't be able to cover during this talk, please feel free to reach out during the Q&A session afterwards. So starting with cardiac involvement in Duchenne, there are two main aspects that we need to focus on. One is heart failure, and the second one are arrhythmias. So starting with heart failure, many young boys and young men with Duchenne are affected by what we call dilated cardiomyopathy. And this is a form of heart disease where the heart enlarges and weakens over time, and it prevents it from pumping blood efficiently. The cardiomyopathy may lead to heart failure, and the typical symptoms are shortness of breath with exertion, swelling of the lower extremities, inability to lie flat, but it may also lead to abnormal heart rhythms, so arrhythmias, or in rare cases, even to a cardiac arrest. And it's important to know that cardiomyopathy does not equal a heart attack. A heart attack is a myocardial infarction where the blood supply of the heart is compromised, and that is typically not a problem that we see in Duchenne muscular dystrophy. So what kind of symptoms do we expect in heart failure, and why is it so difficult to diagnose? Well, first of all the symptoms that we typically experience in heart failure are related to exertional intolerance. And I can't ask young men with Duchenne or once they're wheelchair bound or have severe skeletal muscle weakness, how many flights of stairs can you climb before you get short of breath? Or what happens if you climb up a little hill? Do you get short of breath? Or if you start running? Is walking okay, but running may be problematic? So you can see that a lot of the symptoms of heart failure that we typically ask as an adult cardiologist are really not valid or applicable if you have underlying skeletal muscle weakness. The other problem is that many symptoms that we typically see in patients who have heart failure, we also see in patients with Duchenne, but not because they have heart failure, but because they have other problems. So shortness of breath, for instance, can be present because you have severe lung disease or weakness of your diaphragm. The diaphragm is the breathing muscle that can be affected in Duchenne. You may have lower extremity edema, so you have lower extremity swelling that is not related to the inability of the heart to pump enough blood, but because you're in a wheelchair and gravity always does what gravity does, it pulls all the fluid in the independent areas, and all the fluid will accumulate in the legs, and because you don't have the muscle pump to pump the blood back from the tissue into the blood vessels, you may experience lower extremity edema. So a lot of typical heart failure symptoms may be present even in the absence of heart failure. So it's very hard to distinguish. So what we truly need is objective data. So what kind of data do we rely on? The first one is an echocardiogram. So the echocardiogram, or short term is echo, is an ultrasound exam of the heart that converts sound waves from your heart into detailed pictures of the heart chambers and structures of the heart. And I'm sure that most of you have seen that, where you have to lie on your back on the left side, and we take a little ultrasound probe with a gel and press on the thorax and try to get really good images of the heart muscle. The next exam is a so-called cardiac MRI that allows us to get really good images of the heart. MRI stands for magnetic resonance imaging, and it's a scan that uses the magnetic field and radio waves to take very detailed pictures of the heart and tissue. The advantage is that we get more detailed images than the echocardiogram, and specifically we can look at scar tissue that is invisible to the echocardiogram. But it's a more lengthy exam. You have to lie flat on your back for 30 minutes, up to 45 minutes. Once you have contractures, it's rather difficult to do. If you have a defibrillator, or if you're trached and on a ventilator, it's more difficult to do. So it can pose some logistical challenges that we usually do not have with the echocardiogram. And another cardiac test that we often recommend is a cardiac CT. It's called it's short term for computed tomography. And it also allows us non-invasively to get good images of the heart. But particularly this is useful for the blood vessels. And in Duchenne, we seldomly do the cardiac CT when it comes to looking at the heart. We may get good images with the cardiac CT for the lungs or for the abdomen, but for the heart, we really focus on the echo and the cardiac MRI. Those are the two main imaging modalities that we have available. So what kind of parameters do we look at? Well, we look at this ejection fraction, or LVEF. LV stands for left ventricular, so that's the main pumping chamber. EF stands for ejection fraction, and it's a percentage. And what's rather confusing is that when we think about percentage, we think that 100% is normal. Well, that's not actually the case. Normal is 55 to 60%. Ejection fraction is the amount of blood that the heart pumps out with every heartbeat. And it never pumps the heart empty. That would be 100%, but about 55 or 60% of the blood that's in the heart chamber at a given time is pumped out. And then the heart fills again with new blood, and again, 55 to 60% are pumped out. So the ejection fraction has to be around 55 to 60%. This is where we really wanted to see. And one of the questions was, well, how does this ejection fraction behave over time? What changes do we see? And here you see age. So age 10 years, 20 years, 30 years. And the ejection fraction is shown on the y-axis. And as I told you, ejection fraction around 55 to 60% is what we typically want to see. And when you're in your young, in your teens or 20s, the ejection fraction for most patients is normal. But over time, as you age, we see involvement of the heart muscle that becomes apparent as the ejection fraction drops over time. So most patients who are in their 30s and 40s have an ejection fraction that is below this 55, 60% criteria. The other imaging parameters that we'll look at besides the ejection fraction is the size of the left main pumping chamber, which is responsible for pumping blood through the body. We can look at valvular disease. Are the valves competent? Are they leaky in any way? And importantly, with the cardiac MRI, we can also look at active inflammation and scar tissue that forms as a result of active inflammation. So those are images that we typically would see on the cardiac MRI. You can see all the four heart chambers, and the left main pumping chamber is shown here where the walls are thickest because it has to do most of the work. And what you can see here in white is little bits of scar tissue that form over time. And initially, just a little bit of scar tissue that forms on the outer side of the heart, on the side of the wall. But as time progresses, what you will see is that there is more scar tissue that forms. And over time, it forms also in different areas of the heart, not only on the side of the heart, but in the what we call the septum, the wall between the right and the left pumping chambers. And then you have more extensive fibrosis over time. And it's important that the more fibrosis you develop, the more your ejection fraction will decrease over time. So initially, when you have very mild fibrosis, the ejection fraction may be normal. And if you do an echocardiogram, which can only look at the ejection fraction, but not at the scar tissue, you will see that everything looks great, when in fact there is already fibrosis, meaning scar present, but it would be invisible to the echocardiogram. And over time, you may see in more advanced stages that the ejection fraction drops. And this is the correlation that we typically see between scar and left ventricular ejection fraction. So the scar is shown here, the ejection fraction is shown here at the bottom. And where you really want to be is with an ejection fraction about 55 to 60%. Those patients usually have very little scar that is shown here. And as time progresses, what happens is that you will develop more scar. And as you develop more scar, your ejection fraction will drop. And this is important because it will tell us important information about this patient. So patients who have an ejection fraction of greater than 45% will do well. They will develop less arrhythmias, they will have less heart failure symptoms, they will require less admissions to the hospital for worsening heart failure, and they will live longer. And that's shown here in blue. And those patients who have an ejection fraction of less than 45%, they tend to have more complication as time goes on. And if you include not only the ejection fraction, but also the scar tissue, you can get a more granular data and can actually predict better who will do well and who won't. So how can we prevent scar tissue from forming, and how can we make a heart that has become weak stronger? And there are a wide variety of heart failure medications that are available. And there are a total of 4 medications that are established. And if you are on those medications, not only do you have a better quality of life, but you live longer. So the first pillar of heart failure treatment are medications like lisinopril or perindopril. They're called ACE inhibitors. An alternative to those medications would be angiotensin receptor blockers like losartan or valsartan. And then there are the ARNIs, Entresto is the medications. That is more powerful. It's sort of a losartan that is much more, or valsartan that's much more potent. You only need to be on one of those medications. So we usually do not combine medications that are within one group. The second pillar would be the so-called beta blockers. Those are medications that protect the heart from seeing too much adrenaline. And they're very useful if you have arrhythmias, and they're also helpful if the heart is weak. They can strengthen the heart muscle over time. The third medications are so-called MRAs. They're similar to ACE inhibitors that they block certain hormones. MRAs block different hormones than ACE inhibitors and complement each other really nicely. And last, there are so-called SGLT2 inhibitors. Those are medications that were initially developed for patients who have diabetes to treat high blood sugars. And then we found that patients who have diabetes and a weak heart, their heart failure actually improved. And the next step was, well, can we give those medications that were developed for patients who have diabetes also to patients who have heart failure but don't have diabetes? And the answer was yes, those patients also did much better. So their heart failure improved. And ideally, we don't want to wait until you have a weak heart to start those medications, but there's really a concept of starting early. And that is very well established for ACE inhibitors. So if we, for instance, see that your echo looks great, but on cardiac MRI, there is already scar in the heart, then this lisinopril is a great medication because it will prevent formation of further scar tissue. And there's really good data in Duchenne that it should be given to all children before the age of 10. Ideally, as soon as you can take medications, patients should be on it. It's also a great medication for patients who have high blood pressure or diabetes. Well, it treats high blood pressure, and for diabetes, it helps to maintain kidney function. Now, I mentioned high blood pressure. The problem that I see in my patients who have Duchenne is that usually the blood pressure is too low. And very few patients with Duchenne have high blood pressure. And the fact that those medications are also used for high blood pressure is actually a problem to some degree, because it may be the dose limiting effect. So I may not be able to uptitrate those medications because that may be limited by low blood pressure that develops. And it's actually a good thing to have a normal or a low normal blood pressure if you have a tendency to have a weak heart. Think about the heart as a pump that pumps blood through the body. Now, if the pump has really trouble pumping, then you don't want to increase the blood pressure, because if the blood pressure is high, it means that the heart has to work extra hard. It increases the workload on the heart. And having a normal or a low normal blood pressure, it's actually very protective for the heart. That makes the heart beat more efficiently. When do we prescribe the beta blockers? Those are the medications that protect the heart from adrenaline, from seeing too much adrenaline. Well, particularly in those patients who have arrhythmias or who have a heart rate that is quite fast, we can use the beta blockers to slow the heart rate. Similarly, MRAs like eplerenone or spironolactone are used for patients who are pre-symptomatic who have already scar, because we know that MRAs, together with the ACE inhibitors, are medications that prevent formation of more scar tissue. The SGLT2 inhibitors like Jardiance or Farxiga, they're used for patients who are pre-symptomatic if they have diabetes. And then we can use medications like diuretics, so water pills, if patients have congestion. So if they have swelling of their legs or if they carry too much fluid in their lungs, we can use diuretics. It's important that diuretics are used for symptom control, but they don't have sort of the same level of evidence that they prolong survival as these 4 pillars of medications that I just mentioned. And importantly, if you use one of those 4 medications, you can reduce death and heart failure hospitalizations by 32%. If you're on 2 medications, you reduce the risk of serious complications by 44%. If you're on 3 medications, 55%. And if you add this SGLT2 inhibitors, you get an additional 25% benefit. So they complement each other, all those medications. And ideally, patients, particularly if they have a reduction in their heart failure, should be on all 4 if they're able to tolerate them from a blood pressure perspective or other side effects. So here is a slide that shows the value of prophylactic treatment. That was a landmark study that was published now more than 20 years ago out of France that asked the question, what happens if we treat patients who are younger than 10 years old and who have a normal ejection fraction? You can see here the ejection fraction at baseline in two groups, in a control group and a group of patients who receive perindopril. That's an ACE inhibitor that's similar to lisinopril. And initially, both groups had a normal ejection fraction. After 3 years, the ejection fraction started dropping in some patients in both groups. And after 5 years, you see that the ejection fraction dropped much more in patients who were on control medication, so who did not receive perindopril. Those with perindopril managed to keep their ejection fraction up for a much longer period of time. And that provided the rationale to recommend ACE inhibitors before the age of 10. And ideally, that should be given even earlier, as soon as boys are able to take pills. So what happens if medications don't work? Well, there is something that we call advanced heart failure therapies. And that includes pumping devices, artificial pumping devices, which we call LVADs or left ventricular assist devices. And then there's the option of having a cardiac transplantation or heart transplantation. The goal of these therapies are to improve quality and quantity of life by restoring heart function. And importantly, whether young boys and young men with Duchenne are eligible for those advanced heart failure therapy depends on mostly their pulmonary status, so how well their lung disease is managed. If their lung disease is already fairly advanced, often the risk of surgery for those heart transplantation or LVADs is considered too high, prohibitively high, and then they're not considered. Previously, we were considering that these are really off limits from all patients with DMD, and there has really been a paradigm shift in the world of heart transplantation, and more young men with advanced heart failure and DMD are at least being considered. The door is not closed from the beginning, so that's really been a big improvement in the community. And this is what an LVAD, so left ventricular assist device, one of these artificial pumps, look like. They're implanted at the tip of the heart. They need a battery pack, and you can either carry it with you, or when you're at home, you can plug this pump in. It has a drive line that goes through the skin, and that controls the pump. Because you're more likely to form blood clots, the blood needs to be thinned. There is data from patients with Duchenne muscular dystrophy who have been using or living with such a pump for more than 10 years without major complications. And then there's the option of replacing a weak heart with a heart transplant. And there are individual case reports from patients with Becker muscular dystrophy, and there are more patients with Duchenne muscular dystrophy. There are more patients with Becker muscular dystrophy, so the milder form of dystrophinopathies, who are considered for heart transplantation. So the next big aspect besides heart failure are arrhythmias. So what are arrhythmias? Arrhythmias are abnormal heart rhythms that occur when the electrical signals that coordinate your heartbeat don't work properly. And they can cause the heart to beat too fast. That is called tachycardia. The heartbeat can be too slow. That's bradycardia. Or the heart can beat irregular. And in patients with Becker or Duchenne muscular dystrophies, most arrhythmias are too fast or they're irregular, but very rarely too slow. It's important that they can originate from the upper chambers of the heart, and that can give rise to what we call supraventricular tachycardias. Some of them, one specific aspect is atrial fibrillation. They also arise from the upper chamber of the heart. Arrhythmias that come from the lower chambers of the heart, from the main pumping chambers, can be either individual extra beats, ectopic beats, what you call PVCs, or the more dangerous arrhythmias are ventricular tachycardia or ventricular fibrillation that can lead to sudden cardiac arrest. Now, many of those are benign and they can just cause palpitations and irregular heart rhythm, but some of them can be associated with serious complications. So atrial fibrillation, for instance, from the upper chamber of the heart can lead to strokes, whereas ventricular tachycardia or ventricular fibrillation arising from the bottom chambers of the heart can lead to sudden cardiac arrest. So how do we screen for arrhythmias? Well, we do an electrocardiogram, and that looks at the electrical activity of the heart. The electrocardiogram, or short ECG or EKG, gives us a 10-second snapshot of the electrical activity of the heart. So if you have arrhythmia at that time, it's actually very useful to get an ECG. Otherwise, the ECG often will show some non-specific changes that are quite typical for, can be very typical for Duchenne muscular dystrophy, but they really don't tell me very much about the long-term risk of arrhythmia. And we have realized that it's very important to monitor patients for longer periods of time, to record the heart rhythm for longer periods of time to screen for arrhythmias. How do we do this? Well, there are wearable Holter monitors, little patches that are applied to the chest, and they stick to the chest firmly. You can have a shower. You shouldn't take a bath when you have this, but it allows to record the heart rhythm for days and weeks at a time. And last, if you have very rare arrhythmias, you have palpitations that happen twice a year. Well, how lucky do we have to be that you have to wear a Holter monitor exactly at that time? So what we can do is there are these implantable monitors, which we call ILRs, and they are injected under the skin. It's a little chip with a battery that's injected under the skin. It can communicate with your cell phone via Bluetooth, and if there is a dangerous arrhythmia recorded, that is either too fast or too slow, it will automatically trigger and it will record this. But you also have the option to open an app on your phone. If you have a loop recorder and say, I felt something, it will go back and it will mark that episode, send it to our clinic. We'll be able to review it, and then we'll know what it is. It will allow us to obtain a symptom rhythm correlation if you have palpitations that are rare. So we did a large study in patients with Duchenne where we did this prolonged rhythm monitoring, either with these patch monitors or with these loop recorders. And we were looking mostly for the dangerous arrhythmias that are coming from the main pumping chamber. And to our surprise, we found a high rate of arrhythmias that were coming from the atria, from the upper chamber of the heart. And that was a little bit surprising. And we find those arrhythmias are atrial fibrillation or atrial flutter. And they are important to recognize because they can make heart failure, if present, worse, and they can also lead to stroke. And we found that about 10 or 20% of patients with DMD who are older than 20 and who have mild to moderate heart failure symptoms, and by that time, most of young men will have some heart involvement, had actually atrial fibrillation. And these episodes were intermittent. Many of them caused very little symptoms and are easily missed. And the best way to detect them was with a loop recorder. And that's important because in my practice, I had two young men who have had a stroke. And we know that it's very, very unusual at this age to have a stroke. And when we compare young men with Duchenne, their risk of having a stroke compared to an age and sex matched population is about 100 times higher. And to a large extent, those strokes, I believe, are caused by atrial fibrillation or atrial flutter that often goes unnoticed. And knowing about it is very important because we can treat it. We can start a blood thinner or discuss a blood thinner at least to see whether there are no contraindications. And if there are none, then most patients tolerate it okay. One of the problems that I've encountered with the blood thinner is that many young men with Duchenne have kidney stones. And if you have kidney stones, you tend to have also more blood in your urine. Initially, that little bit of blood doesn't cause any problems, but if you started on a blood thinner and you have kidney stones, that may lead to more significant bleeding. So that's important to recognize. And if young men with Duchenne are symptomatic with atrial fibrillation, if AFib causes palpitations, then antiarrhythmic drugs often can help with those palpitations. Now, the other arrhythmias that we're particularly concerned about are the arrhythmias coming from the bottom chamber of the heart, called ventricular tachycardia or ventricular fibrillation. These may lead to palpitations, passing out episodes, and worst case scenario, even sudden cardiac death. Now, the major risk factors that predict whether a patient will develop ventricular tachycardia or ventricular fibrillation is the ejection fraction and the presence of scar tissue. Just going back to the prior slide, so this is really where you want to be, that your ejection fraction is high, above 60%, and that you have no scar. Those patients that are located to the left are those patients who have scar and a low ejection fraction. Those patients are at highest risk of arrhythmias. So how do we treat those ventricular arrhythmias? Well, the main thing is that we want to prevent the ventricular tachycardia to happen in the first place. So managing heart failure with medications is really the key. So again, the 4 pillars of treatment, it's prevention, prevention, prevention. If we can keep your heart strong, the risk of arrhythmias is really low. If arrhythmias happen, then we can start thinking about antiarrhythmic drugs and possibly also ablations. And last, if there is a high risk of ventricular tachycardia, and we say, okay, we're not able to prevent every single episode, but we really want to prevent sudden cardiac death, then defibrillators, or ICD, which is short form for implantable cardioverter defibrillators, are the way to go. And it's important to know that the very first defibrillator, one of them is actually, this is one of my patients with Duchenne who received a defibrillator. The very first defibrillator worldwide was implanted here at Johns Hopkins in 1980, and we've come really a long way. The devices have become much, much smaller. So the defibrillator is a little computer with a battery that we implant under the skin, and that's connected to the heart with a wire. And that wire is threaded through a vein that runs under the collarbone and goes all the way into the heart. And that defibrillator sits there and monitors your heart rate 24/7. If you have a normal heartbeat, it will just continue monitoring. But if it detects a dangerous arrhythmia that is very fast, the defibrillator will be active and it will be able to shock you out of it. It's what you see in the movies where they put the pals on the chest and they shock you. That's what the defibrillator does. And for selected patients who have a high risk of sudden cardiac death, then the defibrillator may be something to consider. And it's the pros are that it's the most effective protection from sudden cardiac death that we have. But it's important to know that, well, if you say, well, it's like having EMS in a box. Why, if it's so protective, why don't we all have defibrillators? Like we would all benefit from it. It's not that simple. It's an invasive procedure. Particularly for patients with Duchenne, it requires anesthesia, and there's a risk of anesthesia-related complications. And importantly, it doesn't treat the underlying heart failure. It just treats a sudden cardiac death, which, don't get me wrong, that's a very important part, but it doesn't make you feel better from a heart failure perspective. If you have an ICD, MRIs are much more difficult to schedule. And the last 2 points are very important. They are low computers with a battery, and unfortunately, computers can malfunction. And there is a risk that you may get an ICD shock when it's not indicated. And if that happens, that can be very, very painful. So there's this risk of inappropriate shocks that we're really trying to avoid. Now, we as physicians have learned that it's very important to avoid those inappropriate shocks because they can lead to PTSD. So we have learned to program those devices in order not to make them trigger happy. And the risk of inappropriate shocks is also much lower these days because those devices have become much more sophisticated, and there are sort of filter algorithms and treatment algorithms in there to prevent, to minimize the risk of inappropriate shocks. But it's important to know that it's still a real concern. And there's a risk of infection, which may require removal of the ICD system. And if you have an ICD that's inside your blood vessel, there's a risk of sepsis, and it may make you very, very sick. So there are different types of ICDs. I mentioned a transvenous ICD that is implanted with a wire through a vein that goes into the heart. The problem there, again, it's a wire that's inside the blood vessel, and that if it ever gets infected or if it breaks, it's very hard to remove the wire because that wire grows into the blood vessel. It forms scar tissue inside the blood vessel. So there are different types of defibrillators that have been developed that remain outside of the blood vessels. One is the subcutaneous ICD that's located on the side, and that has a wire that goes across the chest wall, and then it's on top of the breastbone, under the skin, but on top of the breastbone. And then there's a third type of ICD. This is an image not front to back, like the subcutaneous ICD, but showing here side to side. And the ICD is also located on the side. There's a wire that goes across, but that wire doesn't go on top of the breastbone, but it goes underneath the breastbone. And because it's closer to the heart, you can make the battery smaller. The image doesn't do it justice, but it's about half the size of the subcutaneous ICD. And it also has added functionality as well. Because the subcutaneous ICD and the extravascular ICD, they don't touch the heart, they don't see the electrical activity as well as the transvenous ICD. They have a slightly higher risk of inappropriate shocks. That's important. So when do we consider those ICDs? Well, in patients who have had a cardiac arrest due to a dangerous arrhythmia like ventricular tachycardia or ventricular fibrillation and are lucky enough to survive their cardiac arrest, we ask no further questions. You get an ICD if this is concordant with the patient's goals of care and clinical status. In patients who are considered high risk and never had any dangerous arrhythmias, these days we usually go by the ejection fraction, which is an incomplete risk marker. And that's important because the scar tissue is also a very important parameter, but our current guidelines do not factor that in. But if the ejection fraction drops by about half of what's normal, so from 55–60% to less than 35%, we at least discuss or start considering ICDs in patients. And I want to conclude my talk to say that we still need to understand much better who is at risk for dangerous arrhythmia and who we should not worry as much about. We're currently doing a study to better understand the natural history of arrhythmias in patients with dystrophinopathies. And importantly, we consider patients who have a cardiac device implanted so we can get data 24/7, that we really don't miss anything. And we include patients who have Becker, who have Duchenne, or also female carriers who either have an implantable loop recorder or a cardiac defibrillator. And we collect basic demographics, medication lists, echo and less cardiac MRIs. We'll look at the ICD interrogations. We ask you about questionnaires of the quality of life. And then we create, based on the cardiac MRIs, personalized heart models or digital twins. And it incorporates the geometry of the heart, it incorporates the scar tissue, and we can correlate that with the arrhythmia data that is seen on the loop recorder or defibrillators. And we hope that with those digital twins, we're much better able to predict who is at risk with Duchenne to develop arrhythmias in the future and who won't. With that, I want to conclude. And if you have any interest, please feel free to contact me. And I want to thank prior sponsors. I had a grant from the Department of Defense, who was in part also sponsored by the parent project Muscular Dystrophy. And the current study is graciously supported by J.B. Keys Foundation. And I want to stop here and thank you for your attention. I'll be happy to take your questions.
Thank you. That was wonderful. And actually, JB's Keys are actually in the same state that I am in, which is Massachusetts, and wonderful family they are. So I'm glad that they were part of that. Dr. Barth, that was amazing, outstanding. I feel like I learned something new every single time. And I feel like I know a lot about my son's heart and cardiac, but every time I do something like this, I learn. Some of the questions that we received, I'll do the easy one first because you and I already talked about this one. Should our guys be drinking caffeine, coffee? Should they be drinking energy drinks? Should anybody really be drinking those?
Coffee, yes. Energy drinks, no. That's the short answer. And coffee,
Perfect.
yes, with certain limitations. If you have 1 or 2 cups of coffee a day or 3 cups of coffee a day, not a big deal. If you have 8 cups of coffee a day, that may be a little bit more of a problem. When it comes to the energy drinks, they have a lot of caffeine, and they also contain a lot of unregulated substances. And most young men who drink energy drinks, they usually don't drink only one, but they drink 2 or 3 or 4 to stay up all night, either for gaming or for, because you're in college, you have your exams, your midterm exams, and then you need to study. And you're sleep deprived, you have a lot of coffee, you have energy drinks. That's not a good combination. That can give a lot of, it can overstimulate your heart with adrenaline and can give rise to arrhythmias. So coffee in moderation, not a problem at all. Energy drinks, please stay away.
Perfect, perfect. You talked a lot about the pillars of medication and the standards of care here. Is that something you see worldwide? Someone was asking, are those standards across the world? Um, do you see in other countries, if you're familiar with it, do they sort of follow the same medication program and perhaps implantables at some point in time?
Yes. So to a large extent, those medications are used for all patients who have a weak heart. And most patients have a weak heart because of coronary artery disease. Those are elderly patients after myocardial infarction where part of the heart doesn't get oxygen. And if the oxygen flow is not restored, the blood flow is not restored, part of the heart muscle is dies and is replaced by scar tissue. And then within a short period of time, you have a big chunk of scar that forms in your heart. That can weaken the heart. Those patients respond to the same treatment. And if you have a non-ischemic cardiomyopathy or dilated cardiomyopathy, as it is seen in Duchenne, Duchenne is one specific form of dilated non-ischemic cardiomyopathy. All those medications, all those four pillars work.
Perfect. Okay, so we had a lot of questions come in while we were talking. So someone asked if a family has history of AFib or other heart diseases, is that more likely to sort of make the guy's hearts a little bit worse? Like, would having family history not necessarily related to Duchenne also be a part of the care there?
The answer is yes. So there can be a double hit. So what we've seen is very rarely there can be some patients who unfortunately not only have a genetic variant that predisposes to Duchenne, but they may have a second variant. And if you have a second variant, a genetic variant that's causing heart disease, that can make the Duchenne muscular dystrophy even worse. And often the second variant is remains gene elusive. We see that there is a lot of heart disease in that family, but with our current tools, we're not able to detect that. And our tools, when we do genetic testing, we can detect one big change. It's relatively easy to pick up if it's in a gene that we know is associated with heart disease. But what if you don't have one big change, but you have many little changes? And those little changes go undetected with our current tools because they sort of fly under the radar. But if you add all those little changes up, you also get a big effect. But again, our tools these days would not be able to pick them up. But a family history of heart disease certainly gets my attention in those families.
Understood. Someone also asked about a 2D echo. Does that give a decent picture of the ejection fraction of a patient?
Yes, so the 2D echo is the echocardiogram. And that's sort of the synonym for the echocardiogram. And the echocardiogram is, I would say, the workhorse for assessing the heart function in Duchenne. It's rather easy to obtain. It's not too uncomfortable for children with Duchenne and for young men with Duchenne. Um, the better test overall is the cardiac MRI. And the cardiac MRI will give us all the information that the echo gives us, but also allows us for information about scar tissue. The problem is that once you have contractures, it's much more difficult to get, and it's an uphill battle at some point, and it may not always be able to, you may not always be able to get MRIs. The other thing that I didn't mention is that for the MRI, you have to lie in this relatively narrow tube, and that's not um, if you have claustrophobia, you may not do well in there. And it's not like you can put headphones on and close your eyes and forget about everything else. But the heart is moving. It's beating inside the chest and you're breathing. So it moves up and down. So you'll be constantly asked during the MRI to hold your breath and you have to cooperate. And it's not like you can go to sleep for during that time, but you really, in order to get good images, you have to um, cooperate. And it's not an easy exam to get.
No,
And
it's not. And I know for Jake, my son, he's quite contracted, and it's rather difficult because of
yeah,
his leg position to get him into the tube. And it's quite uncomfortable, especially if you're injecting the dye, right? So that adds time on to the MRI time wise, right? Whereas if you're not doing that, which may not show your scarring, right? So there's that. But I know that I wish this day and age where we are in this world, we should be able to have something else that it's a little bit bigger for these guys to get into. And you would think, and you definitely can't sleep because the sound is quite loud. And I usually sit outside of it, so I hear it. I hear it as well. Another question about pulmonary function. Does that also affect the cardiac condition if they're, weak pulmonary wise or diaphragm wise?
Yes, they're all, it's all what we call interdependent. If you're not breathing well, the first thing that you will notice is that you may be breathing well when you're sitting up, but you have very little reserve when you're lying down. And this often happens at night. And we see that a lot of young men with Duchenne have central and sleep apnea, and they may require BiPAP at night. And this is really important. So BiPAP is sort of a positive airway pressure that helps to support the diaphragm and helps you to breathe. You initiate the breathing, and but it helps you to breathe during the night. And you can imagine if you don't get enough blood into your body, well, you won't sleep well, and your heart, amongst many organs, won't like it. If there is very little oxygen in the body, what happens is that your heart rate, first of all, will slow down. I mentioned that we see slow arrhythmias or slow heart rhythm very rarely in patients with Duchenne. We see it at night when they're not sleeping. And it's because they have too, or when they're sleeping, because they have too little oxygen. And the answer is not to put a pacemaker in to stimulate the heart, because it's still a heart that doesn't get enough oxygen. It's a heart that's not unhappy. The answer is to restore the oxygen flow to the heart. And the problem is that not only do you get the slow arrhythmias, but once after a certain time passes without oxygen, all the alarm bells go off in the body and tell you breathe, 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 breathe. And those alarm bells are stress hormones. So you get glucocorticoids, you get cortisone, you get adrenaline, and you get this rush of adrenaline, and that rush of adrenaline can actually put you into atrial fibrillation, can create ventricular arrhythmias. So it's very important to treat those pulmonary problems, that you can breathe properly. That will help with a lot of arrhythmias.
So that's a good announcement to all of those out there who don't like to use their BiPAP machines, that they should start using them, right? And I think it's important too for the care team, right? So cardiac and pulmonary, I think it's important, obviously, for them to communicate so that, everybody knows what's going on. We talked a little bit about medication, and you talked about the lowering of blood pressure. I know that when we go in and Jake gets his, blood pressure taken, it's low, and they look at him and they say, "Are you okay?" So I often go in with preemptively saying it will be a little bit lower. It's okay. It's normal for him. But some of the medications, as you know, can reduce the blood pressure. So are there different, you talked about the four pillars, and within like say one beta blocker or one ACE inhibitor, there's a few different types of medications. Do you find that you sometimes will try one medication, and if it continues to lower the blood pressure, maybe try something different? Um, like metoprolol, bisoprolol, carvedilol, those kinds of things. Are there different things that you try, different, strategies to keep it from not going so low, the blood pressure?
Yes, and frankly, with the blood pressure, yeah, so there are different, permutations, different combinations of those medications that you can try to tailor that to the individual patient needs. And I think this is very important to discuss with your doctors. There's nothing that's written in stone, but ideally you should be on all those medications and try different combinations to find the one combination that works for you.
Hmm.
When it comes to low blood pressure, I tell patients to a large extent, ignore the low blood pressure. You will all have low blood pressure. What really matters are symptoms. Do you have any symptoms? Do you feel very tired? Do you feel very fatigued? Or do you feel dizzy, lightheaded? That's something that we need to discuss. But if your blood pressure is 100 over 60, or 90 over 50, or even 80 over 50, and you feel great, fantastic. Just continue your medications. Don't worry about the blood pressure. The key with those medications is to start them slowly, and as you introduce them slowly, you will be able to tolerate them better. If I hit you with a high dose from the beginning, you're less likely to be able to tolerate it. So go slowly but steady. I think that's the key. And
Absolutely. And drink lots of water, right?
drink lots of water. That's exactly very important. If you're dehydrated, the blood pressure lowering effect of those medications is more pronounced. And we may be able not to treat your heart as we would like it to be because you're just not drinking enough. And frankly, this is a problem. I mean, young men, if they have limited mobility, they don't want to go to the bathroom, there may be no aid there, and then you restrict yourself, and it's not good. And the other problem is if you restrict yourself with not drinking enough, you're prone to kidney stones, and they hurt. So it's really important to stay well hydrated. Yes, it's inconvenient, but it really helps us to treat you with the right medications. Usually this becomes a problem if patients have home nursing who come and they monitor the blood pressure. Oh, when should I hold those medications? Then you have to specify parameters. But more importantly, it's a problem when you get admitted to the hospital. And then there's often that something is going on. It's perfectly fine during this initial time to hold those medications, those blood pressure medications. And even importantly, if you have a day or two at home when you just don't feel well, or you have fever and you sweat more, you lose more body fluids, and you may not be drinking enough, then your blood pressure is lower. It's perfectly okay to hold at least the lisinopril or the angiotensin receptor blocker like losartan, valsartan, the Entresto. And that is okay because they're the most blood pressure lowering medications. And once you start feeling better after 2 or 3 days, once you recover, you can restart it. It's not a problem for 1 or 2 or 3 days if you hold those medications. The benefit that we see with those medications is really long term. It's not a sprint, it's a marathon.
No, absolutely. And I think it's important to have that conversation with your physician to talk about the medications and when you may be able to hold them, not hold them, things like that. I have a Google Doc, a worksheet, and I've been taking my son's blood pressure since 2022 because it's also important if you go to the emergency room where they're not familiar with Duchenne to know your baseline. And included in that, I put when he starts medications, when we go up so that you can really monitor everything. I'm not much of a binder person. I sort of need everything online. And the good thing about that was when my son was in college, the aides would also do that. So we always had a good indication of how he felt that day, what his blood pressure was, and things like that. So I think it's important to know the baseline so that you don't get so scared. But I do have to say, troponin is a really big topic right now. And I don't remember when Jake was first diagnosed, when they didn't take that test, right? When we went to clinic, troponin was not one of the blood tests that they took. We went to the emergency room and his troponin was super high. In the normal population, that would be scary. And but we learned over time that that may happen to Duchenne Becker individuals. So talking about troponin, and I don't know if you could specifically say, but when is it scary? When should you really be concerned? And I think you should always have an open dialogue with your physician as well so that the ER doctor can make that connection. But when, should these folks, parents be really scared? And when is it okay?
All right, I think that's an excellent question, and I think you touched a lot of different important aspects there. So first of all, what is troponin? Troponin is a blood test that we typically that get that indicates that there's injury to the heart muscle. So classically, we get that for patients who have a myocardial infarction, have a heart attack, where the heart doesn't get enough blood, a large part of the heart muscle dies, and if the heart muscle dies, that leads to troponin release, and it can be a very high troponin release. Now, this is not why troponin is elevated in patients who have Duchenne. But if you go to the emergency room, there is we don't want to miss any patients who have a myocardial infarction, a heart attack, so they get troponins on everybody, and they will see that the troponin was very mildly elevated, and this is quite common in patients with Duchenne. And you'll see that there is a chronic troponin elevation. You don't see this dramatic rise that you see in in a heart attack, but sort of chronic low-grade troponin elevation. The other thing that complicates things is that previously we had a troponin test that was less sensitive. Now we have what we call high sensitivity troponin. That is about 1,000 times more sensitive than our previous test. So all the numbers will be completely different. And you'll pick up little changes. So many patients who have scar in the heart, well, how does the scar in the heart develop? It's because there is chronic low-grade inflammation. We see that on the cardiac MRI as scar, but if we get a blood test, we see that you have these little bouts of inflammation, and those bouts of inflammation give rise to troponin. And this is important to recognize that it's not a heart attack. So this is where the ED physicians need to be, that if they know that there's prior blood work available that showed already a troponin elevation, it's a young patient, and there is an alternative explanation, then usually they say, okay, we know why this is happening, and it's less anxiety provoking. But it's important to know. And troponin is an important biomarker because if I see that you, for instance, you have a normal ejection fraction, the echo looks great, but there is low-grade troponin elevation, well, that tells me that there's really something going on in the heart and that we can influence with medication. So I need to be more aggressive with my regimen to suppress, the remodeling that's going on in Duchenne.
Absolutely. One question that you had a study slide that you had up. Somebody was wondering if are you enrolling patients in that study?
Yes,
And
yeah,
and what would be the best way? We can share your contact information as well, but so they would reach out to you
yes.
specifically?
Please email me and we'll get you enrolled. That'll be very
Perfect.
helpful.
Perfect. One of the things that I wanted to hit on a little bit was carriers, as I am a female with dystrophinopathy. Do you see some of these medications being used more for carriers and maybe some of the implantables and things like that?
Yes. I think that's very important. And the the same medications that work to treat heart failure also help to prevent heart disease in many carriers. Previously, we thought that it's only about 5 to 10% of women who are carriers will develop heart failure symptoms. Now we know if we look with cardiac MRIs, for instance, that about 50% of carriers will have some very subtle forms of heart disease, some early forms of heart disease. And this may impact the heart not necessarily because it becomes weaker, but it may become stiffer as you also tend to form scar. And preventive treatment is very important in that setting too, to prevent complications down the road. So the short
Absolutely.
answer is yes. We may not be quite as aggressive, but it's very important to treat you as well.
No, that's great. I know we're getting towards the end of our time here. I just wanted to go back to medication, when to start. One of the things that you mentioned was as soon as maybe the child can start taking medications would be a good time to start. Is that would be for like the lisinopril, that sort of
Correct.
class of medication?
So disclaimer, I'm an adult cardiologist. I don't see any children. But when I talk to my pediatric colleagues who treat patients with DMD, the recommendations to start treatment at the age of 10 was sort of a consensus statement together with the neurologist. I think if it was by the cardiologist alone, I would say, well, as soon as you can take medications, why wait until you're 10? This is not, there's no point. This will progress. So the earlier you can start treatment, the better it is. And yes, every medication has some potential side effects, so that's important to recognize. Lowering the blood pressure, lisinopril can raise potassium levels, so they need to be monitored carefully. We need to monitor the kidney function, so it has some important implications. But in general, those medications are very well tolerated, and the benefits by far outweigh the risks.
Perfect. So kind of in summary, right? You talked about the four pillars of medication. You talked about the implantables that can help. So it certainly sounds like, from when Jake was diagnosed in 2011 to now, there have been so many great strides, with cardiac, and so many different treatments are available for these guys, but you're still always looking at the heart and making sure it's okay. I'm going to finish with one last question. And can you talk a little bit about pro-BNP? Just like a quick overall, because that's also another test behind troponin that I'm starting to hear a lot as well.
Yeah, it's also an excellent question. So what is the proBNP? The proBNP is a blood marker that tells me whether a heart is failing or not. So if the heart is failing, the heart enlarges because there's more pressure that builds up inside the heart, and this pressure from inside the heart will lead the heart muscle to secrete more proBNP into the bloodstream. So if you have a low proBNP, that's good. If you have a high proBNP, that can signal heart failure. And I wish there was sort of a single test that we use and that can give us all the information. But it's more like a puzzle that you put together. And the echo is important, the cardiac MRI is important with the SCA information. And then whether the troponin is elevated, the proBNP, that will all give us important information. And it's very possible that the echo is relatively good, but if we see that the troponin is elevated or the proBNP is elevated, that tells me, well, I need to be more aggressive with my medications. The normal EF is still normal, but may not remain normal for much longer unless we, become more aggressive with our treatment. So it's an important part of our diagnostic criteria. And it gets
Absolutely.
actually more important later on as it's more difficult to get cardiac MRIs. Sometimes even the echoes don't give us good images. And having a blood test that we follow over time, and if we see that the proBNP goes up, that is a clear signal that we need to be, stepping up with our medication.
Absolutely. Okay, well, we're at the end of our webinar. I can't believe the hour's already gone by. Dr. Barth, I'd like to thank you so much for everything that you do for the community. We have so many questions, I couldn't even get to most of them. I just thank you so much for your guidance and your experience and just everything that you talked about, the pillars and everything. So we just appreciate so much your time. I appreciate you very much as a cardiologist that my son sees. So I appreciate everything that you do for sure. So all of the questions that we weren't able to get to, and I'm sorry, I will go through them and I can share them with Dr. Barth and we can respond, as quickly as we can. Maybe we'll do another Ask Me Anything. We'll invite you back and maybe we can dive into some of those other questions and that would be wonderful. And
My pleasure.
yes, and I can share your information if anyone wants to get involved in the study that you're working on. So
Fantastic.
again, thank you so much. Thank you everyone for being here. I appreciate you spending your afternoon with us, and I hope you all have a great rest of your day.
Thank you so much.
Thank you.